I would like to bring up fulminant hepatic failure because this is something that's very serious but could easily be dismissed or misdiagnosed. You will not see this often, but when you see this, you should think of fulminant acute hepatic failure and liver necrosis. What you'll see is areas, patchy areas of decreased echogenicity with prominent portal vein walls, and areas that look normal. They look echogenic, but they're actually normal areas of liver. You look back at these, this is the starry night pattern reflecting acute edema or necrosis, and these are areas of normal or regenerated liver. So they come in patchy areas. This is a case that we recently had of a 22-year-old man who came in with jaundice, and we saw areas of the liver that had increased portal vein brightness, and we thought that that looked like acute hepatitis, yet other areas of his liver seemed to be normal. He did have jaundice, and he was not that sick. However, his bilirubin was close to 30. He eventually got up to 30 in the hospital. And he became so sick that he ended up with a liver transplant. So what happened in this case? It turned out that he was using herbs, certain herbs for bodybuilding, and apparently developed some kind of toxic effect from these herbs, and developed liver failure and ended up with a liver transplant. I have seen such situations happen. One case was a sulfa drug reaction, a woman who was on sulfa drugs for bladder infection, who came in as an outpatient and had this appearance. So we thought that something was very unusual and wrong. We sent her to the emergency room, and after I followed her up in 3 weeks, I found out that she too went into liver failure and had a liver transplant from sulfa drug reaction. Another patient that I had, that I recall with this pattern, was a 34-year-old woman who was weak, a little bit jaundiced, and I thought also outpatient setting, and I thought, gee, this liver, something's very wrong. I sent her to the emergency room, and on follow-up I found out that within 24 hours she was dead. Autopsy revealed that she went into heart failure. She had lupus myocarditis and lupus hepatitis and developed this acute fulminant failure. So these are unusual cases, nonetheless serious, and we should not dismiss such an appearance. If you're not sure, if it doesn't look like it matches the clinical picture, we should send the patient right away for evaluation. The fatty fibrotic pattern is opposite. We have increased echogenicity of parenchyma. There's some kind of infiltration with fat or fibrosis going on in the liver, which increases the echogenicity high enough that it matches the portal vein walls, and the contrast is lost. Therefore, we do not see the echogenic portal vein walls. In this pattern, we look at the echogenicity, that's increased, but then we have to look now at the echo texture. It could be a smooth, homogeneous echo texture of the parenchyma, or could be heterogeneous or coarse. Sometimes we see sound attenuation, and this type of pattern is usually seen with fatty infiltration, but also seen with chronic hepatitis and cirrhosis. So here's the fatty fibrotic pattern with the homogeneous echo texture. Here's the fatty fibrotic pattern, loss of portal vein walls, with the heterogeneous pattern. Notice we almost see little tiny rounded masses throughout, a little bit nodular. That's what gives it this heterogeneous appearance. Let's look at the fatty liver. Fatty livers are of this pattern, echogenic, loss of portal vein walls. When it's a very pronounced case, there's so much attenuation that we can't even image the hemidiaphragm, as we have in this case. We've tried to increase the TGC curve posteriorly, and we cannot fill in with echoes. Notice how nice and homogeneous this pattern is. Now, fat can do two things focally. We can have focal fatty infiltration, and we can have focal fatty sparing. Okay, here's focal fatty infiltration, where we have areas of fat. Now, the fat part is echogenic. Fat areas of fatty infiltration interdigitating between areas of normal liver parenchyma. And we also can have focal fatty sparing. Here are areas of normal liver, not affected by the fatty infiltration. You look carefully, you see little vessels inside. There's no distortion. This is a completely normal little liver pattern. That's areas of normal liver spared. These can possibly be confused with liver masses. However, they occur in a very typical location around large portal veins, around fissures, and subcapsular. So we tend to look in those regions, and we look for internal architecture and see that it's not distorted. Cirrhosis has this fatty fibrotic pattern. Now, when we make a diagnosis of cirrhosis, we look for heterogeneous echotexture, so coarse sometimes that it looks moth-eaten, and it's from these little islands of regenerated tissue mixed with diseased tissue that causes this heterogeneous pattern. The livers tend to be small and shrunken. They have a nodular surface. Often there's ascites to help us delineate the surface. And these are the livers where we can see the enlarged caudate. So if you see an enlarged caudate to right lobe ratio, and if it's over 0.73, that's a 99% specificity for cirrhosis. It's not sensitive, but it is specific. Here's a cirrhotic liver. Try to imagine what you would see on ultrasound. You see these nodular areas of regeneration all throughout. In between are these fibrotic bands, and that gives this nodular appearance, sometimes micronodular, sometimes the nodules are bigger, and sometimes macronodular appearance. Look at these tiny little islands of regeneration inside the liver, which cause vascular channel disruption, etc.